Welcome to the deep dive. Today, we're really getting into something critical for us as spine surgeons. Odontoid fractures.
That's right.
Specifically, we're focusing on non-union, why it happens, what influences it, and what the long-term picture looks like based on the research out there.
Exactly. Odontoid fractures, they're common enough, but non-union is a real headache. Understanding the factors, the natural history, it's key for how we manage these patients.
And it's an area that's still evolving, right?
Yeah.
Lots of debate.
Definitely. New studies keep refining things.
Okay, so let's start with the anterior approaches. Anterior ventral screw fixation, AVSF. What's the thinking there?
Well, the goal with AVSF is internal fixation, trying to keep morbidity low, get good fusion, and crucially preserve that C1, C2 motion. It's often referenced for specific types, like unstable posterior oblique or horizontal fractures.
Right, motion preservation is a big plus if you can get it. So what's the evidence look like for success?
There's some strong data. Let's look at Eep et al.
Hmm.
That was a 2010 retrospective cohort in orthopedics and traumatology, surgery, and research.
Okay.
They reported a 95% union rate. Pretty high. That was in 36 cases, mix of type 2 and 3, average union time about 5 months. They mentioned using a curved awl for reduction, which is interesting.
95% is impressive. What else supports it?
Go back further, Chiba et al., 1993, European Spine Journal, another retrospective cohort. They saw 93% union in 44 out of 45 patients, type 2 and 3 again, using just a single screw. Healing took around 5.2 months on average, and importantly, 90% who fused had good head rotation afterwards.
So single screw worked well there.
Yeah, they found it effective for fresh type 2s, high type 3s, even some older cases.
And more recently.
Shetty et al. 2018, Revista Brasileira de Ortopedia retrospective again. In 85 patients with well-reduced fractures, they hit 95% fusion.
Well-reduced being key, I imagine.
Absolutely. They recommended it as first line for those well-aligned acute type 2s, including IA and high type 3s.
Okay, so AVSF definitely has potential for high union rates in the right situations.
It does, but things can go wrong. Non-union is still a risk, and we need to know what drives that.
Right. Let's talk factors influencing success or failure. Cho and Sung, 2012 in Spine, retrospective cohort.
Yeah, they looked at type 2 and shallow type 3. Found about 80.5% bony union overall. But here's the kicker. Surgical delay. More than 1 week. Non-union risk shot up like 37.5 times higher.
Wow, that's huge. 1 week makes that much difference.
It did in their cohort, statistically significant, and also a fracture gap. If it was 2 millimeters or more, the non-union risk was 21 times higher.
Okay, so timing and reduction quality are paramount.
Exactly. Interestingly, age and initial displacement weren't significant factors in their specific analysis.
What about surgical technique itself? Kyagi et al., 2018 World Neurosurgery, another retrospective cohort.
Their union rate was a bit lower, 83.7% in 49 type 2 patients. They highlighted technique points, achieving bicortical purchase with the screw, getting both cortices for better hold, and avoiding breaching the top back tip of the odontoid seemed important for alignment.
Okay.
And they found, unsurprisingly, that horizontal displacement over 2.5 millimeters, or just generally poor alignment, worsened the odds of union.
Reinforces the need for precision.
Absolutely. Precise technique is critical for AVSF.
What about imaging and screw number? I think Mayer et al. Looked at this, 2016 European Spine Journal, retrospective cohort.
They did. And they used CT scans for analysis, one key finding. CT might show lower actual bone union rates than plain X-rays suggest.
That's important. We might be overestimating fusion based on X-rays alone.
Potentially. They also saw a trend, almost significant, suggesting 2 screws might be better than 1 for fusion. P equals 0.06. So close. But they did note high C1, C2 stability with AVSF overall.
2 screws often feels more robust. What about older patients specifically? Daly et al., 2008 retrospective review.
Focused on the over 70s. They found stability in 81% with AVSF, and they saw a big difference with screw number. 96% stability with 2 screws versus only 56% with 1.
That's a stark difference.
It is. But they also flagged a high rate of dysphagia, difficulty swallowing in that older group, a definite concern.
Yeah, dysphagia post-op is something we always watch for. Hrobalik et al., 2008 prospective cohort this time. Acted Chirurgia Orthopedicae et Traumatologiae Czechoslovakia.
They actually reported 100% bony union in 50 patients, which sounds amazing.
It does. Any caveats?
Well, they did see recurrent displacement in about a quarter of them, 26%, more often in the anterior oblique fracture types. And they noted trends towards more displacement with just 1 screw and also in patients over 70.
Right. Even with eventual union, stability during healing can be an issue.
Seems so. And finally, Ye et al., a 2023 neurosurgery technical note, really summarized the challenges. They pointed to the inherent issues. That vascular watershed zone in the dens, the limited bone surface area for fusion. These make AVSF tricky, and they reiterated the known risk factors: osteoporosis, older age, poor bone apposition.
All right, those patient factors.
Yeah, all contribute to non-union risk with AVSF.
Okay, let's try and synthesize that on anterior approaches. AVSF looks like it can give great fusion rates, especially for those acute, well-reduced type 2s, maybe some type 3.
Yes, potential is there.
But success really hinges on a few things. Timing, got to be quick. Reduction, got to be near perfect. Fixation, 2 screws seem better than 1 generally. Fracture pattern matters. And patient factors like age, bone quality are huge.
And don't rely solely on X-rays for fusion assessment. CT gives a clearer picture.
Right. And keep potential complications like dysphagia in mind, especially in older folks.
Exactly. It's a powerful tool, but needs careful patient selection and execution.
Okay. Now let's shift gears. Posterior approaches, specifically C1, C2 posterior dorsal fusion.
Right. This is often the fallback, or maybe even primary choice in some situations.
When would you typically consider it?
Well, definitely for symptomatic non-union after AVSF didn't work, or if AVSF just isn't feasible from the start, maybe the fracture anatomy, patient body shape, whatever.
Lay on rationale.
It uses a much larger fusion area on the back, the posterolateral aspect. This bypasses that tricky vascular watershed zone of the dens itself.
Makes sense biologically. Downside.
The big one is loss of rotation. You're looking at potentially losing about half your neck rotation.
Significant.
Yeah, but for some patients, maybe older, less active people, that trade-off might be acceptable for stability. And it's also an option for fractures you just can't reduce well enough for screws.
Got it. What's the evidence say for posterior fusion outcomes?
Let's look at Huang et al. 2019 Journal of the American Academy of Orthopedic Surgeons retrospective cohort.
Right.
They looked at younger adults, 18 to 64, with type 2 fractures, used temporary posterior screw rod fixation. On CT, they got a 94.8% healing rate.
Very high in that group.
Yeah, suggests low non-union risk with this approach in younger patients.
But maybe not always fusion at the fracture site itself. Yamaguchi et al. 2022 Surgical Neurology International retrospective cohort.
Right, they offered a nuance. Looked at 15 type 2s treated with C1, C2 posterior fusion, only 60% fused at the dens fracture.
Only 60% at the dens. Where else did it fuse?
Fusion also happened at the Atlanta dens interval, the ADI, in 67%, and between the C1, C2 lamina in 27%.
Interesting. So the overall construct gets stable, but not always by healing the original break.
Seems so. They also suggested that maybe preoperative alignment like the C2-C7 SVA and getting fusion at the ADI might actually predispose against fusion at the dens itself in some cases. Maybe altered biomechanics, stress shielding. It's complex.
What about just using the instrumentation for stability? Bison et al. 2015 Journal of Neurological Surgery Part A retrospective cohort.
Yeah, this was intriguing. 12 type 2 patients, posterior fusion with various techniques, 11 fused across the fracture site, all 12 fused somewhere. But their suggestion was interesting. Maybe in younger patients not suitable for AVSF, just putting in the posterior instrumentation without aggressively preparing for fusion at the fracture site might be enough to stabilize things and allow the fracture to heal on its own.
And then potentially remove the hardware later? Preserve motion?
That was the idea. Provocative thought, needs more study, but interesting.
Definitely. And Shetty et al., that 2018 study we mentioned for AVSF.
Right. They compared posterior fixation too. It actually had a slightly better fusion rate overall in their cohort, 96.5% versus AVSF's 95%. But they emphasized the significant neck movement restriction. So they reserved it mostly for AVSF failures or when AVSF wasn't an option.
Okay. Any specific scenarios where posterior really shines?
Well, complex cases. Katavi et al., a 2020 case report in Journal of Orthopedic Case Reports, they managed a neglected non-union malpositioned dens in an ankylosed spine, needed an anterior release, then posterior occipitocervical fusion.
Wow, complex salvage.
Exactly. And Patkar, 2021 Journal of Neurosurgery Case Lessons, a case series, looked at irreducible, unstable odontoid fractures.
Tough ones.
Yeah. They did an anterior open reduction, manipulated the facets, then followed with either an anterior plate or C1, C2 posterior fixation. Got 100% fusion in 15 patients. Addressed the instability too.
So posterior, maybe combined approaches for the really difficult ones.
There should be a reliable strategy there.
Right. Summarizing posterior approaches. Looks like a solid option, especially if AVSF fails or isn't right. Fusion rates generally high, though maybe not always at the fracture site.
Right. Stability comes from the overall construct.
Biggest drawback is the loss of rotation, but it's effective in complex situations, neglect, irreducible fractures, sometimes combined with anterior work.
And that idea about instrumentation potentially allowing healing in younger patients is something to keep an eye on.
Agreed. Okay, let's tackle non-operative management. Always a big question, especially in the elderly.
Huge topic. And the data is, well, it's varied.
Start with Rodenbush and Molinari, 2015. Geriatric orthopedic surgery and rehabilitation.
Yep.
Retrospective cohort. They looked at older patients, right?
Yes. Over 70s, minimally displaced type ties treated with just a rigid collar for 12 weeks.
And the non-union rate?
Strikingly high, 88% non-union.
88%. Wow. But how did the patients do?
That's the interesting part. Despite the non-union, survivors reported low pain, low disability, and high satisfaction. Mortality seemed linked to their other health problems, not neurological issues from the non-union.
So maybe radiographic non-union doesn't always equal clinical failure in this group.
It raises that question. Now, compare that to Smith et al., 2013, spine, a prospective cohort, also elderly type 2s treated non-operatively.
Right.
Their non-union rate was lower, 22%, but over 60% of those non-unions ended up needing surgery later. So overall, primary or secondary non-union was 30%.
So a fair number still failed non-op treatment eventually.
Yes. Their 12-month mortality was 14%, but they didn't find a difference in outcomes at 12 months based on union status. Although, again, many non-unions had surgery by then, which complicates interpretation.
Right. What predicts non-union with non-op treatment? Cloney et al., 2023, Clinical Neurology and Neurosurgery, retrospective.
They looked at isolated odontoid fractures managed non-operatively, found that type 2 morphology and a larger fracture angle were significantly associated with non-union. Older patients were more likely to get non-op management in the first place.
Makes sense. Fracture pattern matters.
Wow.
What about the type of non-union? O'Mara et al., 2025, a look ahead in the Spine Journal.
Yep.
Retrospective cohort.
Yeah, large cohort, 300 conservatively treated type 2s. They broke down non-union, 25% unstable non-union, 48% fibrous non-union.
Unstable versus fibrous. That sounds crucial.
It is, because they found 6% of those with unstable non-union developed new neurodeficits after the collar came off. That's worrying.
Definitely. Risk factors for unstable non-union.
They identified male sex, osteoporosis, osteopenia, and more baseline displacement. But they did suggest fibrous non-union can be a stable outcome.
Okay, so fibrous non-union might be acceptable. Florman et al., 2022 World Neurosurgery Systematic Review looked at this.
Yes, focused just on fibrous non-union, 141 patients. Found no neuro events, mostly good pain scores, mild moderate disability, high satisfaction, but big but inselected patients.
Selected how?
Near anatomic alignment, no dynamic instability on imaging, normal neuro exam, low risk of further neck injury. Careful selection is key.
Understood. Wilson et al., 2021, Journal of Neurosurgery. Spine, retrospective cohort.
Looked at 80 non-op type dyes, found 22% instability at follow-up. Instability was linked to having myelopathy already, cerebrovascular disease, and dense displacement of 2 millimeters or more. Age itself wasn't linked.
What predicted stability?
If they were stable on initial upright x-rays, they tended to stay stable. Also, interestingly, the operative group in their study had more complications overall, like respiratory failure, and they echoed that fibrous union can provide stability sometimes.
But there's a counterpoint. Hung et al., 2018 World Neurosurgery Retrospective, Elderly Non-Op Type 2s.
Yeah, a bit more concerning. 50 patients, over half had their brace removed despite non-union on x-ray.
Okay.
But the non-union group had shorter life expectancy than the union group, and one patient developed quadriplegia and dysphagia during follow-up. So while taking the brace off might seem reasonable in some elderly non-unions, there are potentially severe long-term risks.
That's a sobering finding. What about collars? Harris et al., 2020, Injury Retrospective, Elderly Type 2s, Hard collar.
Mean age was 80. They found only 37% bony union with the collar, compared to 80% in a surgical group. And collar complications were high, 37%, mostly pain and stiffness.
Collars aren't benign.
Not at all. Though again, they found functional outcomes were often good, regardless of union status.
It's a complex picture. Risk et al., 2013, Clinical Neurology and Neurosurgery, case series. Non-op without myelopathy.
59 patients. Only 27% bony healing. 60% fibrous non-union, 13% persistent instability, and about 16 ultimately failed non-op treatment. Highlights that even in stable-appearing patients, you need close monitoring.
What about halo vests? Older study, Lind et al., 1987, spine.
Look at 75 unstable cervical injuries, 14 were odontoid. Only one type 2 nonunion in the halo group. They felt fracture gap and type were factors. Halo seemed well tolerated and gave high healing rates in their series.
Halo is less common now, but maybe still has a role.
Perhaps in select cases. And one more specific patient factor. Wolded, 2018 skeletal radiology retrospective, looked at CPPD.
Calcium pyrophosphate deposition disease,
Teach-
pseudogap.
Right. They found a massively higher non-union rate in CPPD patients, 90% versus 32% in controls for type 3, even with similar initial displacement. Something to consider if you know the patient has CPPD.
Definitely adds another layer. Finally, Walker et al., 2021, Archives of Orthopedic and Trauma Surgery. Retrospective, older adults, semi-rigid collar.
125 patients, 65 and older, type 2, semi-rigid collar. High non-union rate, again, 71%. And 40% of those were unstable non-unions.
But how do they feel?
Interestingly, no significant difference in pain, disability, or quality of life between union, stable non-union, or unstable non-union groups based on patient-reported outcomes.
That's counterintuitive, especially for unstable non-union.
It is, and it suggests that in this older group, maybe the clinical impact of radiographic findings isn't always what we'd expect. Conservative management seemed relatively safe in their cohort, despite the high non-union rate.
Okay, summing up non-operative management. It's an option, especially for older or sicker patients, but you expect higher non-union rates than surgery.
Much higher.
The type of non-union matters immensely. Stable fibrous might be okay in carefully selected patients. Unstable carries real neurological risk.
Absolutely. Factors like fracture pattern, displacement, osteoporosis, CPPD influence the outcome.
And while some elderly patients do surprisingly well functionally despite non-union, we can't ignore the potential for instability, complications, or even impact on survival seen in some studies.
Yeah.
It's not a simple decision.
Not at all. Close follow-up is essential if you go non-op.
Right. Now, what about the long-term natural history? If someone has a non-union, what happens down the road?
Well, it's not always straightforward. Polinsky and Papadopoulos, way back in 1994 Neurosurgery, published a case report.
What was the point?
It was the first documented case of a non-union happening after the fracture seemed healed on x-rays, a delayed non-union.
So healing isn't always permanent.
Exactly. It tells us we need long follow-up, maybe more than 12 months, with imaging to be sure.
How common are these chronic non-unions?
Yeah.
Kepler et al., 2014, the Spine Journal case series.
They looked at elderly patients, 133 type 2 fractures, found about 30% were actually chronic non-unions, often picked up on scans for a later fall or issue.
30% is a lot.
Yeah.
Any consequences?
Yes. Nearly 18% of those with chronic non-union developed new neurological deficits after a second injury. Shows these aren't always benignly stable forever.
They're vulnerable.
Right. And non-unions can sometimes cause problems on their own. Shamji et al., 2016 Surgical Neurology International case report.
What did they show?
A rare case, a chronic hypertrophic non-union. The bone tried to heal, got bulky, and caused progressive myelopathy from compression. Needed a big surgery. Anterior transoral decompression plus posterior fusion.
So the non-union itself can become compressive.
It can, though it seems rare. And going back to Cloney et al.'s 2023 neurosurgery study comparing operative versus non-operative,
Yes.
they found surgery was associated with better myelopathy scores at follow-up, suggests intervening might prevent or treat that kind of neurological issue better long-term.
Makes sense. Are there any fracture types where non-union is less of a concern? Quinton and Ramnath, 2021 Curious Case Report on vertical fractures.
Yeah, vertical odontoid fractures are different, less common. They suggested these often don't need surgery and can heal well with just bracing if there's no instability or ligament injury. Pattern matters.
Okay, so long-term picture. Non-union isn't one thing. Some might be stable fibrous unions, asymptomatic. Others can become unstable, painful, cause neuro problems, especially after another injury or just over time.
Correct. Chronic non-unions might be more common than we think, and hypertrophic ones can cause compression. Long-term follow-up seems pretty essential.
Definitely. Lastly, let's touch on mortality. Does having an odontoid fracture, or how it's treated, affect survival?
It's often tied to the patient's overall health, especially in the elderly. Rodenbush and Molinari's 2015 study on non-op geriatrics.
The one with high non-union but good satisfaction.
Right. They found the average time to death was nearly 4 years, but deaths were mostly from other medical issues, not the non-union itself. No one developed myelopathy before passing.
Okay. What about Smith et al.'s 2013 Prospectus study?
They found 14% 12-month mortality in their non-opera elderly group, but importantly, no difference between those who united and those who didn't.
But is mortality always high regardless?
Mm-hmm.
Farber et al., 2018, Archives of Orthopedic and Trauma Surgery.
They look specifically at octogenarians, 80 plus forward, found a very high one-year mortality, 41%, regardless of whether they had surgery or not. Suggest in the very elderly, the injury itself might just be a marker of overall frailty, and long-term survival is poor anyway.
That's a sobering statistic.
It is. However, Cloney et al.'s 2023 study comparing management types did find an association.
Which was?
Surgery was linked with lower 30-day and one-year mortality compared to non-operative management in older adults.
So maybe surgery offers some survival benefit, at least short to medium term.
That study suggests it might. It's complex, likely confounded by selection bias, healthier patients getting surgery, but it's a data point suggesting potential benefit.
Okay, so mortality is heavily influenced by comorbidities, especially in the very old. But there's some signal, maybe, that surgery could improve early survival rates compared to non-op.
That seems a fair summary of the current signals. Long-term survival in the very frail elderly remains a major concern either way.
Right. So bringing this deep dive to a close, we've covered a lot of ground on odontoid nonunion.
We have.
We've seen AVSF can work well, high fusion rates possible, but it's very sensitive to timing reduction technique.
And patient factors. Posterior fusion is reliable, especially for salvage, but cost rotation.
Non-operative treatment, high non-union risk. Fibrous union can be okay, but unstable non-union is dangerous. Needs very careful selection and monitoring.
And we hit the key factors influencing union. The fracture itself, type, angle, displacement, the surgery timing, patient age, bone quality, even things like CPPD.
And the long-term story is variable, from stable and asymptomatic to unstable neurological issues, especially with later trauma.
And mortality often reflects overall health, but surgery might have some survival edge in certain older groups.
So for you, the spine surgeon listening, the takeaway seems to be, this requires a really personalized approach, doesn't it?
Absolutely. You have to weigh everything. The fracture, the patient's health, their activity level, the risks and benefits of each approach. Balancing fusion, complications, function, quality of life. It's tailored medicine.
There's no single right answer here.
Not at all. It's about applying this evidence, this understanding of non-union risk and consequences to the individual patient sitting in front of you, and hopefully future research keeps giving us clearer guidance.
A crucial point. Thanks for walking through this complex topic with us, and thank you for joining us for this deep dive on odontoid fracture non-union.